a 30-year-old woman married for 6 years and desiring conception presents with the radiological film shown. Male factor evaluation is normal. Her serum AMH, FSH, LH, TSH, prolactin levels are within normal limits. Endometrial biopsy shows no evidence of tuberculosis. First question I want to ask you all, how many of you in your hospital have this protocol of ordering endometrial biopsy to rule out tuberculosis before ordering HSD for a patient? How many of you people do that? We don't. Many of the peripheral colleges do not have this habit of ordering a tuberculosis rule out test to endometrial biopsy before ordering an HSD. But let me tell you, I'll give you, yes, raised your hands, that was nice. I will tell you one patient, I still remember the patient's name. We lost that patient to abdominal pelvic tuberculosis. So patient underwent an HSD somewhere periphery in Bihar. She was referred to AIMS with severe abdominal pain. A TO mass was identified. We thought it could be, we were not very clear with the diagnosis, but because of acute abdomen, patient had to be taken up for laparotomy in the middle of the night. Intra-op findings, the patient had multiple spontaneous bowel perforations and it was all tuberculosis. It was a completely frozen pelvis. We could barely even see the uterus. We tried to do a little bit of separation, and the moment we were doing very, very gently, there were two surgeons involved. Yes, Tejaswini has very sincerely attended this lecture. I wanted others to learn this lesson. We were doing those careful dissections, and the moment we were trying to touch the bowel would give away. It was so delicate that time. Patient had such a bad flare-up of tuberculosis, and there were so many multiple perfs at different levels in her intestine that even the resection anastomosis or resection colostomy ileostomy was not possible. Patient would have landed up in shortcut syndrome. We had to just open and close with a drain. We lost that patient on day 3, day 4 of post-operatively. So ruling out tuberculosis is very, very important. Before you order HSD, be careful with whatever you do. These are actual protocols, especially in a country like India, where we are endemic with tuberculosis. By the way, it's an open declaration in an open session. I myself had a lymph node tuberculosis during my PG time. Like post-thesis, 5th and 6th semester in PG is like very hectic post-thesis. I had exams, I had so many things coming up and bad immunity, and I got lymph node tuberculosis and I was on ATT for a good of 8 to 9 months. So TB can be really bad. And it's a humble suggestion to all of you, no matter how much work you have, please have your breakfast before you go to hospital. Like talking like a mommy right now, but yes, at Conceptual, we do care for all of you. Bilateral hydrosalpinx is the absolutely correct. What does it look like? Does it look like something called as a tobacco pouch, kind of a typical pattern that we study? Yes, what is the most? So one more thing I want to tell you all, TB, pelvic tuberculosis or TB in gynecology kahin se padna is only JB Sharma sir's book. Nothing else, nowhere else. You'll get tens of signs by sir's name. Just read sir's book ka chapter on pelvic tuberculosis. Today also, if I have to read anything in TB, I'll go back to sir's book. What is the most likely diagnosis based on the film? Yes, you will not write tuberculosis directly. You will write it as bilateral hydrosalpinx with no spillage, distal block rather, which drug is commonly administered prior to this procedure and the rationale for its use. Antispasmodic, hyoscine, yes, any kind of an antispasmodic can be given. State 2, meftaspas is also given sometimes. State 2 common conditions that can lead, rotin or hyoscine, absolutely right. State 2 common conditions that can lead to this radiological finding. 2 common conditions. PID, yes, that is what I was looking for, Dr. Yesha, very good. Mention 2 further surgical management options for this conditions if you have to offer any kind of a surgical management to this patient, what it could be. First is medical management, salpingostomy, salpingectomy. Why will you go for salpingectomy? Yes, you can go if the patient is for IVF. Salpingectomy can be given. Clipping if patient is for IVF, not otherwise. Other than that, anybody else? I'm really sorry for this. Fluid aspiration. Some people do fluid aspiration, but it is not very good. Assure, no. Again, only in IVF cycles. Again, Assure will prevent intrauterine implantation. So Assure not a very good choice. Neosalpingostomy can be done. Neofimbrioplasty can be done. The fimbrial end has to be opened, so fimbrioplasty can be offered to the patient. That is what I was primarily looking for. Next question. I'll come back to this. I have a few other things to discuss before I want to come back to this. Yes, Priming gravida, 39 weeks of gestation, high this, presence in spontaneous labor, fully dilated for past 1 hour with vertex of -2, capital plus, grade 2 molding. Decision was taken for LSCS. Will you do LSCS at this? Distal tube block, yes, Dr. Ankita, we do fibroblastic for distal tubal block. Okay, so this is the clinical case scenario. List 4 intraoperative complications that may be anticipated during the cesarean section in this patient. What are the things that you are anticipating in this patient? Keep writing your answers. I am coming back. Aspiration, bleeding, pulled up bladder, hemorrhage, pulled up bladder, bladder injury. Bladder के अलावा और किसी चीज से डर नहीं लगता क्या तुम लोगों को? मतलब why bladder, 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 lower segment here? Yes, Ankita, true. How many second stage cesarean sections have you all done? Raise your hands. Angle extension, perfect. Yes, that is more scary than bladder or anything else. I think bladder, so you can suture. How many of you have done second stage cesarean sections? How many of you have injured bladder ever in your cesarean sections and repaired it yourself or assisted in repairing? Answers, please. Good. Dr. Modi. Second stage CS done. Yes. So Agatika, I'm seeing your posts where you are doing a lot of surgical hands-on work. So good. I'm happy for you. You're getting a good surgical exposure. Anybody else who's done a second stage cesarean? So where I'm working currently, it's a civil hospital where there are like 8 to 10 cesareans in every call duty, and we are like tired of doing cesareans. We don't do at all unless it's a very, very complicated. All second stage cesareans are done by my PGs. Trust me. And I think in every other call day or every alternate call day, there is one or the other second stage cesarean that is happening. Patwardhan, absolutely right. How many of you have attempted Patwardhan method themselves? By the way, last 2 weeks back, I did a cesarean of one of my own gynae colleagues. She's a gynae consultant with me, and it was a second stage cesarean, which is one of the dreadful things to do. I always prayed कि कुछ भी हो second stage cesarean नहीं होना चाहिए. 2 days back, one of my very close friend, both husband wife, DM neuro in PGI Chandigarh, his wife also landed up in a second stage cesarean. Okay. Once you do only, then you get to learn. Na? So I always tell my PGs कि I'm sitting outside the OT, you call me if the baby gets stuck. If I'm standing inside the OT or getting scrubbed with them, no, so they will never get that confidence of delivering. Now, if there's nobody inside the OT, they know anyhow they have to take the baby out. You teach them once, you teach them the right method to do, and then let them do on your own. I think that's the right way of letting anybody explore their surgical skills, right? Fetal pillow, yes. Anything else? 4 intraoperative complications. Bladder, everybody said ureteric bladder injury, angle extension. 4th is broad ligament hematoma. All right, what is fetal pillow? Yesha, Dr. Kanish, can you tell to your colleague, Dr. Yesha, what is fetal pillow? Second is state any 2 precautions that can help prevent these complications. 2 precautions is 1, you can disimpact the head and deliver the baby. Second is Patwardhan technique. Third, you can do is vaginal push. Like you can ask one of your colleague to disimpact the baby's head from vagina and then pull and push. Yes. For pull and push method. Name 4 techniques that can be used to extraction of the impacted head. You have all answered, I think. Fetal pillow is not easily available everywhere. I think I have shown in one of my lectures also long back the image of fetal pillow. So next time, whenever there is a labor room Friday and we're discussing with cesarean sections or anything, we'll try to put the images of the fetal pillow and other things. Not easily available in our country. I have not seen one physically myself. I usually deliver them by Patwardhan method. So Patwardhan also, it's not easy. For people who do not know what Patwardhan method is in a second stage cesarean, once you're given very important technique, dissect your bladder very carefully. Dissect it as low as possible. Let it go even जितना हम hysterectomy में वो cervicovaginal junction तक भेजते हैं, let your bladder sit as low as possible. That is the first thing you have to do. Don't be in a hurry to deliver the baby. Dissect your bladder very, very carefully, as low as possible. First trick. Second is go as high as possible on uterus. The bulge that you are seeing after your skin incision is usually the cervix. It is the cervix which has ballooned up in a second cesarean section. Identify the LUS. There is a sharp, dent. You will see the contour changing. There will be something. It's a speed breaker, You'll find a dent over there, uterus or your cervix. So give incision at this margin or slightly even above that. When you will give a high up margin, don't give incision on the cervix. Very, 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 very important. Don't give incision on the cervix. You'll land up in soup. Give incision as high as possible. Go, मतलब skin को और अच्छे से ऊपर retract करो, then you will find that bulge. go as high as possible. इतना high दोगे तो फिर obviously you will end up with seeing shoulders. Head नहीं दिखेगा बच्चे का. उस time पे you will see shoulders. Extract the anterior shoulder out. Go inside along the back of the baby. Hook the posterior shoulder. Try to rotate it anteriorly. Rotate the back anteriorly. Ask your assistant to give a fundal pressure. ऊपर से fundal देके deliver the back and deliver the buttocks and then pull the baby out. Like the neck is delivered that way. That is how what Patwardhan is done in a good manner, in a sequential manner, in a non-panicky state. Patwardhan se acha kuch nahi hai. People who panic, not everybody knows a correct method of doing Patwardhan. Done in a wrong manner, it will cause uterine artery laceration, it can cause ureteric injury, it can cause extension of your angles, it can cause broad ligament hematoma and whatnot havoc. बाद में संभालते रह जाओगे, it will be very difficult. So learn the right method of doing Patwardhan. Watch videos 10 times. Ask your consultant SRs to make you scrub in second stage cesarean sections. If you are mastering a second stage cesarean section, previous LSCS, everything will become easy. And if it is an obstructed labor kind of labor or prolonged labor kind of a situation, give rest to the bladder post-operatively. Put the catheter for longer duration, at least 48 to 72 hours. Remember that.